and make sure we're live on the other thingies. And then
It says we're live. The
it
stream is
says
live.
we're live. Okay, you guys are live. I'm removing.
All right. Good morning, everybody. I'm Michael Meneghini, orthopedic hip and knee surgeon, and author of the Incision Point newsletter on Substack and LinkedIn. And it's a pleasure today to have a great conversation. I think we've all been talking about, which is the migration from inpatient to the outpatient world, particularly ambulatory surgery centers, of some of the more complicated procedures and how it's really changing the face of healthcare. So it's my pleasure today to be here and have a conversation with Dan Lee, who I've known for the last couple of years, and we've worked together both in his original role, and he's got a long history and experience with journalism, and we worked together at the Indianapolis Business Journal, some of the ventures there together, and then fortunate enough to have him be part of full-time at Indiana Orthopedic Institute. So Dan, if you don't mind, introduce yourself to the community a little bit, and excited to have a great conversation today.
Sure. Thank you, Dr. Meneghini. My name is Dan Lee, and I guess my title is marketing and content manager for Indiana Orthopedic Institute. Been here since January and spent most of my career, the majority of it in journalism, but quite a bit also in marketing. I was, like you mentioned, I was most recently with the Indianapolis Business Journal covering healthcare. I had also previously covered healthcare for the Indianapolis Star, technology for the San Jose Mercury News. So love the intersection of the both in entrepreneurship and innovation. And actually worked briefly at IU Health about the time you joined and worked a little bit on the orthopedic service line. So I've known who you were for a long time, which is kind of an interesting thing. When I was at the IBJ a little bit more than a year ago, and you were opening up our Noblesville surgery center and clinic. And I ended up doing a series of stories on you and on Indiana Orthopedic Institute. And in my mind, I kind of contrasted that with other healthcare entities I was covering, the big hospital systems, some of the things going on. I covered a lot of state legislation involving healthcare costs and prices. And I would sit through these hearings that lasted hours, sometimes in person at the state capitol, sometimes streaming online. And very rarely would any of the witnesses or testimony given be speaking to the heart of the issue. And it was frustrating as a journalist, like, you know, and then executives from certain entities or lobbyists would pull you aside to have these off the record chats. And then they would try, but then they wouldn't even offer anything direct there. And then so I come out and do interviews with you, and I just ask a few questions, and we just start talking about the heart of issues in healthcare and your experience from decades of orthopedic surgery and dealing in a big health system and making a big choice to come out of that. And so us coming to work together and me leaving journalism for something I saw as incredibly valuable and exciting in Indiana Orthopedic Institute started with just an email I sent you, like a one-line email. It said, like, if you need a content person, please keep me in mind.
It was something like that.
Yeah. So my heart's in this venture with you. And I want to go back. Back in last November, I did a big profile about you, kind of a personality profile that was actually just about my most popular, most clicked story at the Indianapolis Business Journal. The headline was "Orthopedic Surgeon Takes a Blunt Approach to Healthcare Reform." And in the top of that story, you had a quote. It kind of gets to what we're talking about today. The healthcare earth is shaking underneath, you said. Now you're referring to a healthcare earthquake. People aren't paying attention, you said. This is a quote from the story. I want to be part of the solution in delivering lower cost, high quality care. And I think that's what we're talking about today. When you talk about an earthquake, and when we talk about just this most recent IBJ article, we have another article that was featured where we're featured in the IBJ, a very balanced, great piece talking about the restructuring of care and this trend towards surgeries outpatient. Because if you just want to start off and just give us a definition of what is this healthcare earthquake for people.
Yeah, thanks, Dan, and thanks for your compliments. And it's a thrill to have you on the team, and leveraging your expertise and your gifts in writing and journalism and content and understanding the healthcare space. you know, as when we first talked years ago, I mean, yeah, the issue that I have, it's the way I was raised by my mother, but the issue I have is I don't hold much back and I speak very directly. And sometimes that gets me in hot water, but I think at the end of the day, when you've got big problems to solve related around patient care, I think the patients deserve that we speak very directly and we get to the heart of the matter quickly, because they don't, many of them are sick or they have diseases that need our help, and they really don't, in all fairness, they don't have time for us to beat around the bush and and talk in passive aggressive ways, or you know, try and be overly polite. They deserve us to lean in and try and solve the issues in healthcare so that they get better. And for us now, you know, it used to be when I was in medical school, you could you could think very altruistically, and I think back then it was in the late '90s, early 2000s. Healthcare had plenty of money in the system, particularly in the United States, but that's not the case anymore. It can't really afford to be 16 climbing to 18% of our GDP in this economy. And the world economy is getting closer and closer to being more intertwined. So what I've learned over 30 years in healthcare is that you have to talk about cost, and you have to talk about the cost of delivering care. And even if you don't want to, the people on the receiving end of it have to talk about cost too. They may have deductibles to meet. They may have employers that are trying to keep their costs down to provide them a good salary or good job for their family, and healthcare costs compromise their ability to do that. So, you know, I think us talking about the issues and framing it in the context of both costs and quality is really important. And that's where we talk about the ambulatory surgery center, because it really represents a lower cost site of care.
Yeah.
And I think that, yeah.
And what is, I mean, just for people, what is an ambulatory surgery center, ACS? I mean, what we talk about that, we have one here in Noblesville. I'm sitting in it. What does it do as opposed to an evolution from like hospital care or inpatient care, the way care has been delivered?
Yeah, you know, it's a very interesting thing. I when we look at ambulatory surgery centers, one of the big issues is it doesn't have the huge administrative burden that some of the hospitals do. It doesn't have massive what we call bureaucratic bloat, right? So yeah, there's been so many studies over the years that have talked about how to reduce healthcare costs, and some of the key studies are, in fact, that that you can just reduce the administrative burden, and it'll cut off. I think one of the latest quotes was almost $290 million. Sorry, $290 billion from healthcare, right? So I got it wrong. B, but M to B. So I mean, that's powerful stuff. And an ambulatory surgery center really strips down healthcare. And I always view it as it strips it down to the most basic level of the doctor-patient relationship, right? It's the core, and everything that is outside of the doctor-patient relationship that doesn't attribute to it, that doesn't contribute to that meaningful relationship, I just would call it excess and fluff. And we have regulatory burden, we have legal burden, we have all these different burdens. And so you build all these layers, and all it does is detract from the doctor-patient relationship, in my opinion. And so that's I think I think that's what's the most challenging, and for healthcare systems and hospitals. The ASC strips it down. It takes about all that, and it really, there's very few people in there that aren't related to that very function of the doctor-patient relationship, and in particular in a surgery center, it's surgery. And by the way, I'm going to ask you, can you hear my dog barking?
Not really.
Like, oh my God. I don't know what is going on in my house. And upstairs, apparently the dog is loose, and it's a little yippy dog. Sorry if you can't hear it too much.
Not too much.
All right, good. Well, I'm about ready to go take care of the dog in a minute if it doesn't stop barking. Anyway.
Yeah. And you know, so we have the surgery center where, you know, these are outpatient people getting procedures here, are going home the same day
Yep.
as they have their procedure. And for what we're going to talk about the heart with the earthquake is there's some changes that have been made and are continuing to be made by CMS or Medicare,
Yep.
which obviously oversees a ton of healthcare in America, and also really helps to set the tone and policies for usually often the commercial insurers follow CMS policy. And so this heart of this last IBJ story was really changes made to the musculoskeletal health, removing from the inpatient only list 285 procedures. We're going to talk about a type of procedure known as a revision. But could you explain a little bit about what that means, that these were these are orthopedic procedures that used to require overnight hospital stays that now, because of innovations, changes, techniques, can now be done safely and for the benefit of the patient. In many, many cases, having them go home the same day.
Yeah, I mean the musculoskeletal procedures are a huge component of healthcare. If you look at the, healthcare systems often refer to the big five. The big five are the big five like revenue generators. They're also the big cost consumers of healthcare, right? There's oncology, cardiology, neurosurgery, musculoskeletal care is a big one. Sometimes they bring in pain and spine but yeah, musculoskeletal health, it constitutes a huge chunk of the healthcare ecosystem. So when they take 285 of the remaining musculoskeletal procedures and wipe them off the inpatient only list, and for the people on that are watching this, the inpatient only list is a list put forth by CMS that basically mandates that certain procedures are done in hospitals. That's why they call it the inpatient only list. And then you're not allowed by CMS to do those patients in an ambulatory surgery center. So it basically keeps them, it keeps them in the higher cost side of care. And that's a really, I think it's restrictive. I think it's also supported by the hospital lobbyists, if we're honest. But it really doesn't put the patient at the center. It doesn't put the doctor-patient relationship at the center, because if you remove it, you allow the doctor and the patient, the healthcare ecosystem, to determine where the patient gets the best care.
Yeah.
So that's really what that is. And I'm gonna let you talk to the audience for 2 seconds. I'm gonna go take care of that dog because he's driving me crazy.
Okay.
All right, I'll be right back.
Go ahead. All right. So for the context of that, why he takes care of the dog upstairs, the inpatient only list means that more procedures are moving from the hospital to centers like Indiana Orthopedic Institute has in Noblesville. And one of those is revision surgery, which is otherwise known as redo surgery for joint replacements. Maybe there was a complication, maybe the joint wore out, there was some other complication. And these were traditionally done in hospitals requiring overnight stays. And in many cases, they still do. But these for knee and hip are a couple of the areas that have been removed from the inpatient only list and have come to outpatient. And this is also one of Dr. Meneghini's specialties, is doing
And I'm
these
back.
revisions. All right, I've been defining revision surgeries because we're going to talk about that for a minute. And so I told them that they're basically redo surgeries. They're more complicated in general.
Yeah.
Surgically, at times they could involve an infection that took hold or a complication wearing out. And this is an area that you've done research on. Between 2020 and 2025, published 3 different articles talking about the ways that these can be done with shorter and then no hospital stays. And so talk a little bit about what went into those 3 different papers. We have a blog about it on our website, but really it encompasses what goes on here in Noblesville with the way anesthesia is done, pain relief, blood loss, things like that.
Yeah, so no, it's great. The revisions are the more complicated procedures that I think, many people believe many people believe they can't be done in an ambulatory surgery center. I think people now will acknowledge straightforward revisions. Like one of them is called a polyethylene exchange, where, both hip and knee replacement is, I always tell people thinking like a sandwich, 2 metal parts with the bone that affix to the bone. And then you have polyethylene in the middle, which is the bearing surface. And sometimes that bearing surface can wear out. And it's not as big a procedure to come in and just take that polyethylene out and put a new one in. And that's on the knee side. On the hip side, it's a head and liner exchange. Same thing. It's the bearing couple. And so it's not as big a procedure. So I think people start off there. And I think I've heard a number of my colleagues across the country say, yeah, no problem, I can do poly exchanges. I think the bigger challenge, but I think also the bigger opportunity for innovation is on routine revisions, not overly complicated ones where there's massive bone loss or the patient's got a limb that's compromised or, a really aggressive infection. those are always going to take multidisciplinary approaches frequently that require probably hospital care for now. Now, again, we'll talk about that in a second. But now we have done research in the last few years because we believe that if you get the similar protocols and pathways for primary hip and knee replacement, and you throw in the surgical complexity into a medically optimized patient, they can do just the same. Now, the issue is keeping costs down in an ambulatory surgery center. We don't have the huge resources. And number two, making sure you can do the procedure safely for the patient with minimal blood loss, anticipating any possible complications, because an ambulatory surgery center doesn't have the space or the resources to have everything, we call it the kitchen sink, everything you might need to tackle a complication in surgery. So you have to have better planning. You have to have a better coordination of care with your industry representatives who provide all the implants and have all the safeguards there. But if you do enough planning in advance, this can be done. And we've shown that. And to your point, we have 3 publications out. And I think right now, in terms of like revisions in the ambulatory surgery center or the same day discharge revisions, I think there's only like 5 papers in the world, and we've published 3 of them. There may be more now, but last time I checked, there was only 4 or 5. And yeah, 3 of them were ours. And we continue to work on how to take this complexity into the ambulatory surgery center. Because if you look at healthcare and look at musculoskeletal, for example, so we're not doing cardiac bypass or anything. So we're doing complex musculoskeletal procedures, but the patient themselves are usually optimized and healthy because it's typically some sort of elective type procedure. We're not doing level 1 trauma, like orthopedic trauma. That's separate. We're talking about elective things. People have implants that are breaking down. People have hip and knee arthritis, or in the case of revisions, they're having something wrong with the implant. And if it's not an acute problem, we can plan. We can plan months in advance to do that. And so, yeah, we publish it that patients undergoing not massive, but routine revisions can go home the same day safely and have a minimal complication rate, even better than what those that were done in the hospital could have.
Right.
And I think one of the things we've always talked about, Dan, and you've heard me talk about this, is you have to prove that the hospital is the safer place for you to spend the night, because most people go home the next day anyway from musculoskeletal procedure. So, and we published a study years ago that looked at what did we do for a patient when they were in the hospital overnight. And we did a number of things. We would in and out cath them because they had urinary retention. That was like, we looked at over 1,000 people, and I think that happened in like 13 patients. And the reality is we've learned how to prevent urinary retention now through preemptive protocols. So now we don't even have that issue anymore for the most part. It's very, very rare. And so when you look at these things, you say, well, what? And then we looked at, okay, what tests are being done? Well, there were like 2 EKGs, and they were normal out of 1,000 patients. We're like, okay, well, we gave fluids. Well, now we know how to do that better. So then we begin to ask the question, why are we keeping patients in the hospital overnight? Like, if we're not doing anything for them, is the hospital just a really expensive hotel? And by the way, in my opinion, this is the beginning. This is where healthcare reform is important, because I believe that taking musculoskeletal patients out of the acute care hospitals opens up the hospitals to care for those patients who are more in need of their services. Now, we can get into the economics of it and why musculoskeletal care is a revenue generator for the health systems and ambulatory surgery centers. But I think that's where people like us who are heavily invested in developing ambulatory surgery centers can partner with hospitals to then put the patient where they belong and help all patients in general. Because if I'm pulling patients out of the hospital that aren't that sick, that I can do in my ambulatory surgery center, then I'm freeing up that for people who have pneumonia or who have massive infections, or God forbid another COVID outbreak happens or whatever. There's all these new viruses that are seeming to try and make another peek at infiltrating our society, whether it's Ebola or the hantavirus on the cruise ship or whatever. Let's keep the hospitals for the really sick people where they do their job well, and let us in the ambulatory surgery center do our job well, keep costs down, provide safe care for patients. And I think one of the examples I like to use is 25 years ago, anterior cruciate ligament surgery, ACL surgery, was routinely done in the hospitals. If someone said to you today, you're going to have an ACL surgery and it's going to be in a hospital, people would look at you like you had 3 heads. They'd be, what are you talking about? Why would you ever do an ACL in the hospital? Well, 25 years ago, that's all they ever did. Hip and knee replacement now is moving into that phase where, Dan, when you and I are in need of hip and knee replacement, or we're even older and retired, and we're whatever we are, people will laugh at the fact that, what are you talking about doing hip and knee replacement in a hospital?
Yeah,
Right?
yeah.
That's
It's really
happening.
about delivering the right type, right amount of care in the right place. And to that, one thing, when I first interviewed, when I was back in journalism, when you were opening the center here in Noblesville, one of the very first things you said to me, as you described it, is you wanted patients to have the experience like if you went to the Ritz-Carlton. I
Yeah.
mean, and you certainly built this building to be pleasant and nice, and there's some function to that with the natural light, but you really meant something deeper than that. Is like when you go to a hotel like that, they know who you are. If you stay
Yeah.
there before, you have a record there, they have your name, they treat you, things are quite coordinated, which
Yeah.
is, I think, such a big frustration of people within the big health system. And we talk, a lot of people internal here talk about this as a one-stop shop. So when people come here for an orthopedic procedure, really there's the right hand is always talking to the left hand.
Mhm.
And whether that's perioperative. So talk about some of the design of how you set up our center here in Noblesville for that new model. And patients comment on it. If you go to our Google reviews, they talk very much about this whole continuity of care, from the waiting room to every type of staff member who interfaces with them, whether it's a medical assistant, nurse practitioner,
Yeah.
surgeon, anesthesiologist, PT.
Yeah. Yeah. No, that's a great point. I think, yes, I used to comment about the Ritz-Carlton because I'd never been to a Ritz-Carlton. My brother worked for Eli Lilly and used to tell me they would go to training courses about customer experience. And, when you come up in medical school and you go to residency, whatever, you're like, customer service, what is that? I don't even know what that means, really. But when you start to put together, and like we did at Indiana University, put together a hip and knee program, and you start looking at how to disrupt the market and make sure patients know who you are, the key is, and it was a pretty interesting evolution, is to basically treat patients like they're customers. And I think you should do that. Uh, and that happened, there's a moment that I've talked about over years when I went to propose to my wife, and I had it all planned. I was going to propose on this at this Ritz-Carlton. I never stayed at one before. My brother's like, you have to go to this one in California, whatever. And there was an orthopedic meeting out there. Not surprised that I'm so insane that I will blend a proposal to my wife with an orthopedic meeting. Anybody who knows me, I'm always trying to multitask like that. Anyway, so there's a huge storm goes, it blows my whole schedule up, and incredibly, the Ritz-Carlton had it all planned out. They knew who I was. They knew, because I mentioned before, I'm planning to propose to my wife. Never communicated at all. I remember I hadn't got a chance to do it on time, so I went to dinner with her. I was grumpy because my whole plan had been totally trashed. And the waiter came up and said, "Are we planning anything? Are we celebrating anything today?" And I was like, "Nope." But I just said no, right, because I wasn't prepared yet. And then we got done with dinner, and we I said, "Is there a place we can go to have a drink or whatever?" So it was this nice. They put us in a nice couch overlooking the Pacific Ocean. It was great. It's amazing, Ritz-Carlton in Laguna Beach. And I get down one knee, very subtle, like it was dark, and I proposed to my wife. And thank God she said yes. And I sit up, and literally I got done, and somebody brings over a plate that says "Congratulations" with strawberry or chocolate covered strawberries. I was like, I looked around like I had no idea what was happening. They were watching the entire time. And I had told the Ritz one time what my plan was. And the storm blew it. My travel plans got destroyed. And they followed the entire thing. And I was so touched by that. That was my first time I'd ever stayed at a Ritz Carlton. Well, here's the business model to that. Where do you think we got married? We were so emotionally tied to that place that when it came time to where we are going to get married and spend a large sum of money to do a wedding, my wife, Sarah, was like, "We're going to go to Ritz-Carlton." So then it clicked. It started clicking. That sort of loyalty for an experience can also build an orthopedic practice or a medical practice and build a brand. And so I came back from that and what my brother had told me and about Ritz, seeing it and feeling it as a customer. I said, well, why when I go to the Ritz, um, or any, even Disney has a very similar customer service model. When I go there, they know I don't have to tell them 18 different times who I am or what my preferences are or whatever. But when you go to a hospital, and it's used to frustrate you, I'd be like, my allergies. Do you have any allergies? No. You go to the next stop. Do you have any allergies? No. And you go to the next stop. Do any of you talk to one another? Like what, why do I have to tell people 10 times what medications I'm on? And no, my insurance hasn't changed and yada, yada, yada. Like it is the worst customer service. And I'm like, why are we, when something is so personal, like your healthcare, why do we deliver such a horrible product? And I could never, to the customer who's the patient, right? And it began to have me think about things differently, that our health system wasn't really patient centered. Frequently it was doctor centered or administrator centered. It wasn't patient centered. And so I think when we built the Indiana Orthopedic Institute, one of the things we wanted to do is vertically integrate it. And for those who don't, when I think about vertical integration, I think when you walk in the door and you see your surgeon and they sign you up for surgery, then you go to the perioperative team. Well, instead of going shipped outside the system or in a longitudinal way to other people to get your perioperative clearance and evaluation, we have that in-house. So you stay in the vertical, right? It's our own perioperative team. They're experts at perioperative. Whereas you might do your primary care physician, they're spending all day taking care of high blood pressure and diabetes. They're not focused on perioperative health. So by building that vertical integration, and then we also have anesthesiologists, and they oversee the perioperative care. And that's subtle as well, because if you had an inpatient model, you might have internists involved or whatever, but we don't have that anymore. We're an outpatient model. And so now we have the anesthesiologists who are putting people to sleep. They should be the ones that clear them to make sure they're safe and working in partnership with us. So that's the vertical integration, that's the coordination. And Dan, I think you're right. I do think people feel it. I think they feel it when they come there. They feel it's not disconnected, and they feel like every stop along the way understands and is focused about their musculoskeletal issue, whether it be an ACL tear or a hip and knee replacement or a foot and ankle problem or hand, elbow, shoulder problem, spine problem. Now we've got all the musculoskeletal service lines. And I think that vertical integration is important to all of them. And I think if we can do that, I think the patients win. I actually think the health systems win. We have a partnership in our Terre Haute market, which is on the Indiana-Illinois border. People know where that is, with Union Health, great executive team there. We've partnered with them for the last 3 years. We are talking with potential partners here in the Indianapolis metro area. And then we have a partner, Indiana University Health up in Fort Wayne. And I do think that the future of healthcare will be partnerships of, and I think ideally physician run outpatient ambulatory surgery centers on the surgical specialty side, and then partnered with hospitals, and then you put the patients where they are most appropriately, safely, and cost effectively treated. And I think that helps the whole ecosystem, in my opinion. And I think what people are spooked about, which is what the IBJ article talked about, is this transition. Most humans don't like change, and change is scares people, particularly in healthcare. But we're moving very rapidly, partly because of the current administration, President Trump and the administration. They tend to move around like a bull in a china shop, right? And with a hammer. So things are abrupt. And so, ripping off the inpatient only list, January 1 of this year, was not subtle, right? It's like, okay, the floodgates are open now, and you put the patients where they belong. And I have no doubt that there's more band-aids about to get ripped off over the next year or 2 or 3. So I think that's where we say the earthquake is happening right now, and I think that's right. But we relish in it, right? We're innovative. We like innovating in change, and I think as long as you do it safely on behalf of patients' interest, it's a very exciting time for us.
Yeah, and as you're doing that, you're trying to build a specific culture here at IOI, whether it's here in Noblesville or Fort Wayne, Terre Haute. We also have clinics in Greenwood and Brazil. And, going back to when I was a journalist talking to you, as a journalist, you come in and you ask all kinds of questions. And I asked you we talked about physician leadership. I also asked you what makes a good surgeon. And I expected you to say things like good hands and calm under pressure, which you did say. But the very first thing you said was to treat patients like they're members of your family, period. That's what you said. That was a quote in there. And then you added on about it leading to good judgment. And so the way I read that was, you're talking about treating patients like family, and that means caring for someone, but it's also deeper than that. It's kind of how you're making decisions.
Yeah.
Because doctors are often asked by friends and relatives, for maybe advice. And they help people navigate that system of like, well, no, you can skip this step. You should see this person, or you should get this procedure right away, not go through these other procedures first. How does that kind of play out in the culture you've built here? It's something we talk about a lot internally, is treating patients like family. And again, it's more than just this warm, fuzzy buzzword of being nice.
Yeah.
Which it is, but it's more.
Yeah, I mean, being a surgeon is there's a humbling, awesome responsibility when someone trusts you enough to go to sleep, and then they put their entire being under your care, and they allow you to open them up and do surgery. And so I used to be, early on in my career, I would almost get overwhelmed by that trust. Now I embrace it and actually appreciate it, value it, and to your point. I even had someone just this week in surgery say, "Now you're gonna treat me like your own mom, right?" I mean, but and I want to make sure they feel that. But if they need that additional reassurance, that they feel like they have to say it, and then I respond back, "Well, of course I will." Then I'm happy to do that. And sometimes if I see people are nervous or apprehensive, but I know they need that procedure, it'll make their life so much better. Then I'll lean into it and say, "Listen, I know you're nervous. I'm gonna treat you exactly like you're my own. I got to be careful, but based on their age, I usually say sister. I don't say mother, and then so every once in a while I've gotten burned. Like, do you really think I'm old enough to be your mom? And I'm like, I look at the screen, I'm like, well, you're 80 something, but okay, whatever. Anyway, I just got to be careful. But in general, I mean, people want that reassurance, and I do think, but you also have to you can't treat them exactly like they're your family, because you might not have the best judgment. Like if you're too close, that's why hospitals have rules. You can't operate on your spouse or whatever. But I do think keeping that objectivity, but also the compassion for knowing that remove all the other extraneous stuff. The administrators walking around with clipboards, the nursing infection control people who are looking for whether you pump 3 times on the hand sanitizer or not. Like, block all that out and just say, I'm here today to help you, because I know you have an illness or something that I was trained to treat. And I'm going to make the best decisions I can, irrespective of your ability to pay, what insurance you have, all that stuff. I'm going to treat you just like my own family. And I think if you do that every day, and I think it takes discipline, because we have all these, we're getting hit upside the head with so many different things, prior authorization from insurance companies, or denying our surgeries or whatever. All these things that make physicians feel out of control and like they don't have control, which is scary for a lot of physicians. That's why there's burnout and all those things. And I think it just takes an additional level of focus and discipline to put your mind in the right spot, to focus on that patient in front of you, with all these extra things coming at you at once. And I as you know, I'm a huge physician advocate, and I'm honored and humbled to be able to be a physician. And so I protect the profession the best that I can, all physicians, not just orthopedic surgeons or surgeons. But I think I fully believe that the overwhelming majority of physicians can do that, and that most of them take every patient in front of them like they're their own family. They may not say it like I do, but I do believe most of them are doing that on a daily basis. They took an oath to do that. I think most of them obey the oath. It's just getting all these other things that are happening around us sometimes make it a little bit more challenging. But I think what we've put together and the physicians we have in our organization, along with many others, really take that to heart and they put the patient first. I see it every day. For us to build what we did at the Indiana Orthopedic Institute, to start from, one surgeon and build and grow and do something disruptive and innovative, everybody had to make sacrifices. All of our surgeons, all of our physicians, all of our team members, everybody's making a sacrifice to some degree to do something special, and it's built around the patient. So it's
Yeah.
exciting.
Yeah. To get back to the earthquake, the healthcare earthquake going on,
Yeah.
what kind of disruptions and changes do you see? I mean, coming with like the way benefits are done, there's a lot of changes with how reimbursement might be happening. There's a lot of talk about things like narrow networks,
Yeah.
employer direct, that kind of play into this larger theme of seeking out the highest performing care, both quality and financially.
Yeah, it's interesting. So we just had this play out this week. Give you an example. So I operate a hospital. The hospital is a large health system, and I had a patient who I replaced her original hip years ago at that hospital system, and her health insurance is a narrow network for that hospital system, a third party uh, provider of her health insurance, but they have a narrow net with that system, and so we're not in that narrow network because we're not employed by that system. We're an independent group. So the prior auth went through and it got denied, and they basically told the patient, you can't have the surgeon who did your original one, whatever, 8 years ago or 7 years ago, whatever it was, you can't have that done, even though he's going to do it at our facility because he's not in network and is on my professional fee. And for those, if those people who don't know, there's two charges that occur when I do a surgical procedure, or there's three: anesthesia, and then there's a facility fee wherever we are, and that happened to be at the health system, and then my professional fee for the work that I do. And so they were saying that the hospital, and I said to the patient, well, I'm actually willing, I'll do the surgery for free or for a nominal amount, cover my team's cost, but I'll do it because it's just the right thing to do, but don't subject the patient to that charge. And why don't you let me do her surgery? I operate at that hospital all the time. I'm there every month. And so we took a phone call with the medical director of the third party health insurer, and they approved that. And they said, well, we're not going to pay your fee, but it's still so crazy. We're not going to pay your fee, but we'll pay the facility fee, and she's going to get a bill that says, facility paid, Dr. Meneghini, zero. So, okay, great. I mean, I literally having these conversations is almost surreal to some degree, but I'm sitting there talking to another physician who works for this insurance company, and she says to me, oh, that's really nice. I mean, it's crazy. It's really nice you're willing to do that surgery for free, which I did. I was happy to. And now the patient is really gracious, and she's like, no, I'm going to pay you what we'll have her bill her what we would pay Medicare or something. But it's super nice that she's willing to pay me, and she wants me to do her surgery bad enough she's willing to do that. But I'm sitting here, she pays for insurance. I'm sitting here talking to another physician who goes, yes, and her bill will say you don't get paid. I mean, think about that. And physicians wonder why we get burnout. I'm going to go do a complex surgery. I've trained, I did 4 years of engineering undergrad, 4 years of med school, 5 years of orthopedic surgery residency, a year of fellowship. I finally get out. My parents are asking me, when you going to get a real job? I finally get a real job at age 32. Then I'm in practice 20 years, honing my skills. And the insurance company says, we're not paying you for your skill. I mean, what profession? No wonder physicians are getting burnout. That's ridiculous. But I just had that conversation taking my kids in to play tennis. I'm on the phone with this lady. She's like, you're not going to get paid for what you do. I'm like, oh God. I mean, kid, you can't buy tennis balls. No, I'm just kidding. I didn't say that. I mean, it's just absurd what's going on. So, I think that's part of the reform that we're going to see. And what I don't know, as employers, patients, payers, hospital systems all look to contain costs, the patient and the physicians, because we're the least, I would say we have the least amount of influence and power, we're going to be tossed around, which we're already getting tossed around right now. And that's what's frustrating all of us. Now, I don't know where it'll shake out and how it'll work. And I think at some point patients will start to look at choosing where they get their jobs, which I think is already happening a little bit, and looking at employers. And as the workforce and labor force begins to evolve and change, that may shape healthcare policy. and maybe it'll make the narrow networks more impactful, or maybe it will maybe the labor market, like you saw this month, it just got announced yesterday, record inflation, the first highest since 2023. So these economic impacts to the healthcare system, it goes back to my original conversation, which is why as a physician we have to talk about cost, because our ability to deliver the kind of care we want to has cost and price involved. It took me a long time to really get my head around that, but it's all impacting what we're doing. But when you get back to the core, Dan, the work we do doing surgery in a lower cost, higher, in my opinion, higher quality ambulatory surgery center is a solution to that problem. doesn't mean that all the stakeholders who are providing the solution are going to get rewarded equally. That's not the case. I see one of the things happening that there was a conference, one of Becker's healthcare conferences for the hospitals was a few months ago, and one of our colleagues, Tony Sorkin, was there, and he said that the tone of the meeting was all the hospitals talking about what their ASC strategies were. Now they're kind of a little bit late because they haven't really started them. I mean, some have, but they're talking about what are our ASC strategies, and I'm thinking, hey, you're just now talking about the strategy, like that the ship's kind of sailed there. The IPO list is gone January 1, but whatever. But that's what you're going to see. You're going to see these hospitals, some of them with large sums of money, start to figure out what their outpatient strategy is. And when they lean in, just like when payers lean in, they have power influence. Many of them have lobbyists. And so it'll change the landscape for sure. And then independent groups like us will have to navigate those waters to figure out how we continue to deliver care to our patients amidst that changing landscape.
Yeah. What would you say, some patients do have those narrow networks. A lot still have kind of a traditional PPO program. But big health systems, tend to refer. They make a lot of effort to keep things in-house, so to speak.
Yeah.
Referral. They talk about, there's some terms in the industry like referral creep or different things. Do you have many conversations with patients that may not even know to explore all their options if they may need surgery or continuing care, that they have more options than they may believe they do? They don't have to stay within one specific health network. With the Indiana Orthopedic Institute, we don't have this big base of primary care physicians or others.
Yeah.
But this is both a question for us, but even more importantly, really for patients to know all the options they may have.
Yeah, I think the healthcare industry is interesting because the insurance world is inherently complex because not every product is the same, and so many patients, including myself, don't know every bit of my benefits. And I probably should, but we find out when we start to get healthcare. And so many patients are shocked. They're like, well, I can't. And that's part of the process. They show up at our door. They want our care because their neighbor, their neighbor, we cared for them or something. And they show up at our door and then they're like, well, why can't I? And they'll get in the door and then they'll see us. And they're like, what do you mean that's out of network? And all of a sudden it's going to cost them more. Well, that's the behemoth that's the insurance company and the hospitals and their interactions forcing patients to go places, right? And because at the end of the day, the patient then have to make a choice. If I'm out of network, I have to pay X, and that's how they control their own revenues and destiny a little bit. But right now, what I would tell you, Dan, is we wouldn't be growing if the market was so consolidated that patients didn't have choice. So, I mean, people still have choice, and it kind of depends on each market. Here in Indiana and Indianapolis, people still have choice. And so not everybody, depends on their plan, but most people have a choice where they go. And we accept Medicare and Medicaid and everything else. So we try and be as open as we possibly can to every employer, but of course, or to every insurance company and even employers. But as you know, some will strike deals with companies or hospitals to keep their costs down and get a deal, and the next thing you know, they restrict who they can go to. Some patients can't come to us, but again, I tend to. That's a lot of noise for me as a leader of this organization. That's just noise. What I try and focus on things we talked about, pulling us back that's noise in the market to me, pulling us back to the mission. The mission is high quality, patient-centered, low-cost care, and deliver it every day you show up. And if we put that model, I believe in healthcare, that model will have value, no matter what all the noise and the chaos and the because if I went to Eli Lilly, if I went to our state government, if I went to where we are in Noblesville, went to the mayor, and I said, I'm going to offer you the lowest cost, right? And let's put the payers and the hospitals, put everybody in a room, and I'm going to say my goal is to provide the highest quality, patient-centered, lowest cost care that I can in orthopedics. Anybody interested? I mean, right? I mean, so it's all noise, and they'll fight, and they'll do whatever they do for their own self-interest. But at the end of the day, as long as we have that product out there, then I think there'll be a demand for it. And maybe I'm altruistic, and maybe that won't happen, and maybe we'll get squeezed out at some point. Maybe we will. I don't know. But right now, we're thriving and growing, and by putting a really good product out there for patients to consume, I would say. Right?
Yeah, yeah. Well, this has been a fantastic conversation, and it's an earthquake going on still that has a lot of peril and promise, I think. Is there anything else you want to close with as far as the direction we're going? We've been adding several new physicians of late. We're just in the process of adding. We just added sports medicine. We're adding foot and ankle this summer, spine right after that. You know.
Yeah, I think, I think the reason it's interesting how we evolved, we started off the Indiana Joint Replacement Institute, focused on hip and knee replacement, and then quickly went to all orthopedics. And there's a reason for that. It's really to go at risk in value-based care models and things like bundled payments and clinically integrated networks. And, we have a partner organization, Health Outcomes Performance Company, or HOPCO, that are really, they're the largest provider of value-based care and musculoskeletal care in the United States, quite frankly, probably the world. And we, by putting together an entire comprehensive MSK platform, we can then partner with HOPCO to do some really innovative value-based care delivery models. And that's exciting to me. I mean, that's, again, going back towards putting the patient at the center, making high quality, low cost care. And, we've got something in the works right now with a clinically integrated network in the state of Indiana, where all the MSK groups can participate and share in upside benefit, get a little revenue for their high quality and low cost and driving costs down. That's exciting to me.
Awesome. Well, I thank you very much for your time. This has been a great discussion, and we'll come back and do this again. And always love your content on Substack and LinkedIn, as well as all the work we do here at IOI.
Thank you, Dan. Great interview, great conversation. Have a great rest of your day, and look forward to doing it again soon. Thank you.
Thanks.